All right. Good evening, everyone. My name is Dr. Chris Wilson, and I am one of the co-founders of the American Palliative Rehab Alliance. And I'm going to be introducing our esteemed team here in just a minute. But I wanted to tell you the American Palliative Rehab Alliance is a group of allied health, physical, occupational therapy, rehabilitation professionals. Our website is palliativerehab.com. So if you are interested in participating or attending, we have lots of webinars out there, lots of different articles, things like that. And I'm happy to introduce my partner in crime and colleague, Ann Henshaw.
Hello, everyone. Thanks for listening tonight. I'm an occupational therapist, and Chris and I are passionate about making this a multidisciplinary effort to help our seriously ill people.
Great.
I'll pass
And
it to Jordan.
yeah, we'll pass it to Jordan and Brenna, who are going to be our interviewers for the day. And they'll introduce Alex Hill, who is our interviewee. And Ann and I are going to take a back seat on this one. So if you guys are tired of hearing Ann and I talk, we're going to keep our cameras off. So you're welcome. And then we'll pass it on to Jordan and Brenna. So take it away, ladies.
Hi, I'm Jordan Humitz. I am a professional year 3 student at Oakland University in physical therapy.
Okay, I'm Brenna. I'm a physical therapy year 2 at Oakland University.
And we're here with Alex. Her specialty is pelvic health in terminal illness and stuff like that. So we're going to ask her a few questions, get to know her, and go from there. So, hi, Alex.
Hello, thank you so much for having me on.
Thank you for being here. I'll start it off. Something easy. Just tell us about yourself and kind of your practice, what you do.
Yeah, absolutely. So my name is Alex. I've been a physical therapist for 10 years now. I went to PT school at University of Florida. And then immediately after I graduated, I did a women's health residency at Duke University. And that's really where I first found my love and understanding for how I could meld pelvic health and oncology together, which has just been truly amazing. So I've been doing pelvic health and oncology and lymphedema for all 10 years ever since I graduated. I currently work in an outpatient hospital-based setting at UF Health in Jacksonville, Florida. And I also have a side business, Oncopelvic PT, where I provide continuing education courses. I do a lot of free social media content online and YouTube videos to try to increase accessibility to education and people learning about their conditions, and do coaching and stay busy, but really glad again to be here and talk about pelvic health and oncology, and especially in the palliative setting, because this is, in general, pelvic health is typically underrepresented. It's not really talked about, it's taboo. And then especially in the palliative setting, like that's even less talked about. So I'm really, really glad to be here.
Awesome. Thank you so much. Brenna will ask the next question.
What does a typical session of pelvic floor PT look like when the patient has advanced cancer or in palliative care?
Yeah, so typically, because a lot of people don't really know what a session looks like in general. So I'll kind of describe that first. So for example, our evaluation, we would do our typical very thorough subjective, asking about their symptoms. In pelvic health, that can include anything from bowel, bladder, prolapse, sexual health, pelvic pain. And then we would typically then do a pelvic exam. And that would include an external and internal exam, either vaginal or rectal, if appropriate, with the patient. And then we would get them started on, their home exercise program. And then with their follow-up sessions, again, just like we would with any other rehab session, just continue to work on those impairments and progress them with their exercises to get them to reaching their goals. In terms of differences with kind of the palliative setting, we may need to be more mindful about the different tests and measures that we're asking, maybe phrase our questions a little bit differently if it's maybe symptoms that we're not anticipating to get better, or that might be getting worse. So we have to be a little bit more mindful of how we're asking those questions. I have, for example, right now, a couple of patients who have metastatic cancer that they've been living with for ranging anywhere from months to years. And so it's understanding where they have that metastasis, where they have some more fragility with their bones, and modifying our assessment and our treatments based on, any types of precautions or contraindications that's associated with that, for example.
And then when dealing with a patient who is receiving palliative care, what sort of processes do you go through in order to ensure that the proper care is given?
So definitely, like y'all mentioned at the very beginning of this, multidisciplinary care is absolutely key. Oftentimes it may mean that they need more than just physical therapy. It may mean that they need occupational therapy or speech therapy or social work help, or a dietitian or nutritionist, or somebody that maybe, as the patient has gone through their palliative care, they're going through their care, that maybe there's somebody that's missing on their care team that really needs to be on their care team. So a lot of additional communication with their referring provider and making sure that they have all the players on their team that they really need, that will be helpful to be part of that journey with them.
We're going to switch gears now a little bit. And I know you kind of mentioned that you have kind of your own little side business. You do YouTube videos, stuff like that. Can you kind of run us through what all that entails and what you have to offer, basically?
Yeah. So I started this business in 2020 as a way to kind of combat the negativity and misinformation and disinformation that was just running so much more rampant in 2020, and to try to put out some positivity and some good vibes out into the universe in 2020 when everything was shut down. That was also the year that, healthcare workers, we didn't necessarily have stability in our workforce. And so with being home more, especially that summer when our clinics were shut down, and, wanting to have a positive impact, that's what made me start Oncopelvic PT. So it started as just a Instagram page, and now over the years it's grown to, all the social media channels and YouTube and all that. But again, my primary goals for it are kind of two pillars in terms of my audience. So one is clinicians, healthcare workers, especially physical therapists and those in rehab, to close the gap on their knowledge in pelvic health and oncology. These are two very niche areas that really shouldn't be that niche when we look at the number of cancer survivors, when we look at the number of people with pelvic floor disorders. 1 in 3 women are going to have some type of bladder issue or incontinence in their life, but nobody's talking about it. So I want to kind of demystify these two areas within rehab. And so that's one pillar. And again, kind of advance oncology and pelvic health rehab care. And then the other pillar is, improving accessibility to resources that people can trust, that are also inclusive and that people can utilize. And so, for my YouTube videos, for example, I've had people comment from all around the world that their videos these videos help them because they don't have anybody near them. And I think that one, like that just, it's incredible and it's amazing, but also like that just shows how much more we need providers that are able to treat these conditions.
Right. So in terms of your videos, is it kind of like a coaching aspect where you do some exercises and then some education?
Yeah. Yep. So especially my my YouTube, and I was actually very resistant to start a YouTube channel because I knew how much work it was going to be. But I just had so many people asking for like full-length videos on how to do manual lymphatic drainage or like exercises to do after breast cancer surgery. And so I finally gave in. And so I try to do a mix between, what we call head talking videos, or basically, Zoom, but you're talking to the camera and basically giving a lot of education and tips. And then exercise videos where I'm showing specific exercises. So that's more of the YouTube videos that I'm trying to put out now, is that mix, like you said.
That's awesome. Yeah, I think like you said, since this topic is a taboo to talk about, there probably isn't a lot of videos out there where people are just head on, this is what you got to do sort of thing. So that's really awesome.
Yeah, yep. That's absolutely true. And then it's interesting too with, on social media, and we've all seen it with quote influencers that will say like sugar, like don't eat sugar, like cancer, eat sugar. It's just and then so many people get scared from what they see online or what they read online, or they go down the Google rabbit hole. And so, I do think that as healthcare providers, like we have a role and we have a responsibility in trying to, put out some of those fires and put out that evidence-based information.
Absolutely. So I know you offer some courses as well. Can you go over some of the courses that you offer on your website?
Yeah, so right now I have one continuing education course that's specifically for oncology rehab providers. That includes PT and OTs. And that is looking at the pelvic health foundations for the oncology rehab providers. So again, this is that goal of closing the gap of care that our patients are getting. When we look at the number of side effects that are pelvic health related, with our cancer survivors, and we are at a minimum screening them, but then not doing anything about them, that's an issue. When we look at the financial toxicity that patients are already dealing with, and then now we're having to add on a whole new course of PT, or the wait time for pelvic PTs and OTs, there's a lot more OTs that are getting into the pelvic health space as well. But like our wait lists can be really, really long. I think right now I'm booking out a couple weeks. I have colleagues that are booking out 2 months. And, when we're working, especially in the palliative care setting, and people need symptom relief. And if it's something that we can do as oncology rehab providers, of providing just some basic bladder health education, or strategies for managing constipation, or sitting positions if they have tailbone pain, then that can make such a huge difference for our patients. And so that's really the goal of this course, is to empower oncology rehab providers to learn those basic pelvic health knowledge and skills that you can talk about with all of your patients. I always tell people, like, there's no internal work involved. So with pelvic health therapy to train, our continuing education courses involve learning how to do pelvic exams on each other. And so, people are thinking like, oh, a pelvic health course, like I can't do that. No, there's nothing internal. It's all online, all on demand. Again, I want it to be accessible. So that's my primary course that's available for oncology rehab providers. And then I do have several other courses that are specific for pelvic health providers. I actually have 2 more that are coming out in actually a week from today, at the end of September, that really focus on oncology and the pelvic cancers, and how do we safely work with patients in the acute phase, long-term, and also in the palliative care phase as well.
That's really awesome. I mean, I just learned something. I'm in PT school. We don't, like you said, it's a niche. You get introduced, but it's not huge. And the fact that like it's not all internal, this is just health in general, like that's huge. So
Yes.
I think that's a huge part of the education that even healthcare providers need to know, that like it can work across all different people, and it's important.
Yes, absolutely. And there's so many ways that you can screen for pelvic health issues, and check for the pelvic floor, and can they do a pelvic floor contraction without doing an internal exam. And a lot of people don't realize that, right? And it's the more that we can empower ourselves, that's only going to be good for our patients.
I agree, for sure. I know you have a list of some products on your website for managing the side effects of cancer. How did you go about making this list and choosing your products?
I think that's a really great question. I think also, as healthcare providers, we have to be very mindful about what companies or what products we promote, because it is so easy to just take the next hot thing and, promote it and, that kind of thing. But I developed this list based on the companies and products that I've utilized myself or utilized with my patients or have come highly recommended just over the years. And then with those products, they're the ones that are, evidence-based, that we at least have as much evidence as we can for them. Because as we know, especially in rehab and oncology and pelvic health rehab, we need more research for sure in these areas. But yeah, so that's basically how I chose them, as just products and companies that I've used before that I trust. A lot of them have also been involved with different types of research as well. That's been really helpful. And so that's kind of how I go about doing that. I kind of vet each of these companies to kind of make sure that they, one, again, are kind of evidence-based, that they're safe products, but also does their mission align with my mission as a company as well?
Awesome. This is a personal question based off of it. As physical therapists, I know we're not technically allowed, we can't prescribe medication. So what would like a conversation look like between you and a patient in terms of recommending these products?
For medication specifically, or? Okay. So I don't have, at least I don't think I have any medications on my site. As you said, like within our scope of practice, we can't prescribe medications. Depending on the State Practice Act, you can recommend over-the-counter products, for example. So it's well within the scope of practice, for example, for pelvic health therapists to discuss and recommend lubricants, for example, or moisturizers or suppositories that can be helpful for people who are dealing with like vaginal dryness or pain with intercourse, especially related to like hormone therapy from their cancer or radiation therapy. So again, medication wise, I always refer to the medical provider. And then if it's something that I'm talking about, for example, like in a YouTube channel, it would be something that this is one of the options that can be, recommended or prescribed for you. Talk with your medical provider about it. So always setting very clear delineations on that.
Awesome. Thank you.
And then as far as interprofessional relationships go, who are the members of the healthcare team that you mostly interact with in the space of pelvic PT and oncology as well?
So the primary providers would be gynecological oncology or gyn-onc. We see a lot with urology, colorectal, and GI, radiation oncology, hem-onc, kind of the typical players that everybody would see, but then with those additional, like I said, like gyn-onc and urology, just to address some of those more urogenital cancers. Those would be the primary kind of oncology team players, but we also work very closely with the mental health therapists and the social worker team. So that can be really helpful, especially in pelvic health, if we are going through things and working on very sensitive things like sexual problems or sexual concerns. Maybe there's different dynamics between the patient and their partner, where now their partner is having to be a caregiver, and that maybe changes the dynamics of their relationship. So from the PT side, it's not just working with them on like dilators or like the physical side of things, but we also need to work with the mental health providers and making sure that we're addressing that component of things as well. So those would be important providers. And then within pelvic health also, because we do provide a lot of education and guidance on like nutrition, especially for like constipation or loose stools, then we can oftentimes work with dietitians as well.
And then for these relationships, how has this improved treatment plans for your patients?
I think the biggest thing that I've seen over the years is that rehab is not thought of as kind of an afterthought as much anymore, where it's just kind of something to like check off of, okay, like yay, we told them about rehab. It's really like, no, we need to get them into rehab sooner than later to try to mitigate some of these side effects. And so as we have more of these conversations, and, you know, I sit in on tumor board meetings with head and neck cancer and breast cancer and gynonc, as we sit in on these tumor boards and participate, and we're not just sitting in the wings of Zoom and just listening, they recognize more of our value and what we can provide for their patients and provide these better outcomes. So I think just having those better relationships and building them really helps, one, getting people in sooner, but also getting people in who maybe wouldn't have gotten those referrals because maybe their dietitian didn't even know what rehab did, but because we've talked with them, now they know what we do, what we can offer. And then so they can kind of request those referrals or at least be screening for some pelvic health concerns too.
Absolutely. And then do you often interact with any of the patients, caregivers, or family members regarding education or just having any conversations with them?
Yeah, not as often in my particular setting, but I do have some people that will come in, for example, to learn how to, as I mentioned before, I do lymphedema therapy as well. So I might have someone who comes in with their partner or their caregiver who is helping to perform the MLD at home for them. So we would teach them how to do MLD, or if we're needing to change something with or training with how to use a different type of toilet or how to get off and on the toilet. So we have, you know, a commode in the treatment room that will go through how do you transfer, how can you position them to be comfortable and optimal for example, having bowel movements. So again, we can do that. It's very, very helpful, especially again with kind of these more intimate ADLs that people are doing every day. But in my particular setting, I don't do that a ton.
All right, next topic. If you can you please share what you view as the barriers as well as the facilitators to providing pelvic floor therapy to patients with cancer who are seriously ill?
I think that's a really good question. So barriers would include, I think, one, just the lack of knowledge from patients and providers about what we do. As much as it has improved over the years, there's still a lot of patients who are missing out on some really beneficial pelvic health rehab to improve their quality of life, improve their pelvic pain, their symptoms that's related to their long-term serious illness. So I think that's the first thing, is just lack of knowledge and understanding of what we do and what we can do. Sometimes it can also be cost or transportation. So depending what their insurance covers, or if there are, for example, only cash-based or like out-of-network PT providers in their area, that the cost of the visits could be a hindrance, especially when you look at all of these other appointments and, again, that financial toxicity that so many people are dealing with as a result of their cancer and their cancer treatment. And then some of it is also, you know, if people only have so much energy to do X amount of things per day, coming to their pelvic PT appointment may not be at the top of their list. So sometimes just the kind of physical ability and that cancer-related fatigue that's so prevalent, those can be kind of barriers as well. At my facility and at a lot of facilities around the country, a lot more people are using telehealth rehab, which I think has been really, really helpful in this population, because if they call in, they're like, hey, like, I just am not feeling up for it today. I don't think I can safely get to the clinic, for example. Then we say, okay, like, how about a telehealth visit so you can at least still work on things and continue making that progress. So you're not having to use your energy to drive to the clinic, and we can use it on working on these exercises or other educational things. Some facilitators for people coming in. I think, like I mentioned before, because rehab is now integrated as part of the cancer center, I think that that's very helpful and kind of reduces that barrier for people to get referred. we have a rehab clinic that's also basically right next to the main hospital, where we have Proton and we have the infusion center. So that way, if somebody's already there on campus for treatment, they can just walk down the hall or walk across the street, and then they're already at their appointment. So I think location wise, that can be something that can be used as a facilitator, or unfortunately as a barrier. And I think just with more and more people being aware about pelvic health, I think that's definitely a facilitator, and talking about these topics that, again, like we've talked about already, that are typically taboo or not really talked about, or it's just screened on a distress thermometer and okay, check, yep, we've asked about it, but not addressing it. Like, that really is changing, and people are advocating for themselves, and asking for these services. I saw a TikTok about pelvic health, like, do we have anyone here?
Right.
So I think just people being more aware of what we do, and that they can do something about it, is a really great facilitator for people.
For sure. And I know you're probably being modest, but what you're doing is definitely a facilitator too. The YouTube videos, all that stuff too. I think that's huge.
Thank you.
Within the legalities of our healthcare, what is one drawback that may prevent patients from receiving the best possible care? I know you kind of said cost and lack of knowledge. I think that kind of goes with it. Is there anything else that it would be a drawback where someone might not want the care?
I think, again, like you mentioned, it's kind of the cost. Depending on someone's insurance, they may not be, or they may only be able to go to certain facilities that maybe has a pelvic health therapist, for example, but maybe not someone who's well versed in oncology, and maybe not be providing the best care. And then, unfortunately, with our in our insurance system and our healthcare system in general in the United States, it's a bit fractured. We are very reactive. And so, this is not uncommon, is, we might request for 12 visits and they give us 3 because, someone who's not a rehab therapist is deciding on how many visits we get. So that can also be frustrating and difficult for people to really get the best care that they need, because we're trying to cram in so much information and education, but not more trauma already through, and even less visits. So I think that is one of the biggest concerns, like kind of legality wise, or really insurance base wise, healthcare system wise, that we're struggling with.
Kind of branching off that and the whole not enough knowledge and education, when you have physicians that are referring patients to you for pelvic health, do you think that they fully know like what you
No.
do and exactly what they're referring for? Or
some, for sure, yes. This is why I love working at an academic hospital, is because we have a lot of residents coming in, we have a lot of fellows coming in, and so as a kind of a clinical specialist and team lead in my role, I make it a point we need to reach out and meet with these residents. We need to have them come and shadow us. They need to really understand what all we do. It's more than just Kegels and checking how you walk, right? Like, there's so much more that we can do. Even, just talking about cancer-related fatigue and bladder, so many things that can improve the quality of life for people. So I do think that is very important for anybody who's in that type of setting, in a hospital setting where there are people coming in to get trained. Have them come and shadow you for a day so that they really understand it. I've had medical providers who I see as patients, and they're like, oh my God, like, I never knew that you did all of this. Like, I'm totally sending more people to you. And so, like I said, yes, there are some that definitely know, like our oncology teams definitely know. But I think when we look out even at maybe our primary care providers, they don't maybe realize all the things that we can do, not just in pelvic health rehab, but in oncology rehab, when, you know, survivors have those decreased visits with their oncologist, they're maybe seeing their primary care more long term, and they're not getting those referrals that they really need because the primary care doesn't understand what can be addressed or not addressed.
I think it even falls short for physical therapists because you'll have a patient come in and you're like, this is something that's perfect for a pelvic floor PT. And some, I just at clinicals I've had a few that know someone that's super good, will refer them right away, and some that don't even recognize that this is perfect for pelvic floor.
Right.
So that's again is just the word and knowing exactly what you're doing and that it's important and knowing when to refer and why sort of thing. I think
Yes.
the why behind it all, that's super important. That
Yes,
doesn't always
absolutely.
get translated.
Yes, yes. I completely agree with that.
Yeah.
And you know, if you talk to especially a lot of pelvic therapists, like they will tell you, oh, I teach my ortho colleagues or my neuro colleagues about what to screen for, how to screen for it, when to refer. And I think you hit the nail on the head. It is literally like you need to screen, but when do you refer and why, right? It's not just if they have leakage.
Right. Right.
And then switching gears here a little bit, do you have any advice or tips for new grad physical therapists or occupational therapists that are looking to get involved in pelvic health?
All the things, yes. So one, I'm not sure if you'll include this in the show notes, but please reach out to me, please email me if you have specific questions. If you're able to get a clinical rotation, even just to experience it, that's fantastic. Going to conferences like CSM, Combined Sections Meeting for Physical Therapists, it's the largest PT conference every year in the US, and the number of sessions each year is growing for pelvic health and oncology. And so even just sitting in on a session or two with these larger conferences that are on pelvic health, watch YouTube videos. You know, I have YouTube videos about like, how do you get into it? Like, what courses can you take? What books should you look at? You know, and even the new oncology rehab textbook that came out, you know, Chris, a little shout out there. There's so much more content on pelvic health and pelvic rehab that has not been talked about before. So luckily, I think there are a lot more resources that are available. I believe APTA pelvic, and I apologize for those of you that are OTs, I'm not as versed with OT resources, but with APTA pelvic health, I believe they have a mentoring program. If not, then I believe they're building it, similar to what we've done for APT oncology, where you can get a 6 or 12-month mentorship with somebody in a particular area. But at the end of the day, if you find someone and you're like, like that kind of looks like kind of intriguing, or like something I could maybe see myself doing, just reach out to that person. Like, we're therapists, like we're nice. We want more people in these specialty fields. So sometimes it's just a matter of reaching out and asking, like, hey, I'm interested in pediatric oncology, pelvic health. Like, who can I talk to, or what are my resources? So it's just finding the right person to connect with.
And then
Oh, I'm sorry. Go ahead.
this is a bit of a of like my own personal question, but what are the steps you take to like become to become specialized for pelvic PT?
I love this question. Okay. So it can start as early as your second year in PT school or OT school, and with taking a level 1 course. So there's kind of two primary companies or organizations within the US that offer these kind of 3 or 4 levels of pelvic health courses. One is Herman and Wallace, and then the other one is APTA Pelvic. And so you basically would go through these series of continuing education courses. The nice thing is, I know, especially with APTA Pelvic, they do offer discounts for students, which is really great for those that are interested. So it would be taking those levels, those again, 3 or 4 levels of pelvic health courses, and then ideally having a clinical rotation in pelvic health, or if that's not available for you, or you don't find pelvic PT or pelvic OT until like later in school and you don't have the opportunity to do a rotation, then finding again, either a mentor or a job that has mentoring available with it, to get that experience. But I think that people getting into pelvic health really do need some type of mentor or someone who's experienced that can kind of help guide them along the way. And then in terms of additional specialization, there are residencies that are available as well around the country for physical therapists, to then further specialize, are typically a year long. And the content with these, they're women's health residencies, but the content does include oncology. So when I did my residency, my first week was literally doing the Norton lymphedema certification. So I started out as a CLT my first week of being a PT, which was really cool. But looking at some of these residency programs and seeing what their programs offer, can be really helpful as well, because some don't offer that, some offer more kind of community-based oncology learning. So, and then for the OTs, there are, again, a lot more OTs that are out there that are providing continuing education courses specifically for OTs. OTs can also take the Herman and Wallace courses as well to get trained. So regardless if you're PT or an OT, there's a lot of different resources that are available to kind of get into these specialty areas.
Do you have any more questions, Brenna?
No, that answered it. Thank you.
Well, that is all of our questions.
Jordan, do you mind if I jump in with a question? You know, I can't keep quiet.
No, go ahead.
I have similar energy to Alex. I just wanted to take first of all, Alex, thank you so much. That was fabulous. I learned a lot, and it's such an important area. I really appreciate you and your time. But I wanted to take us a little closer, sort of the palliative or the end of life space. For a patient, for instance, and I've had many that are metastatic breast, specifically metastatic breast, and intimacy. Because that's, you know, well, toileting, yes. And that's, I think we both deal with that in terms of, you mentioned getting on and off toilets, and maintaining that independence is critical for people, right? But really, with regards to body image, if you've had a double mastectomy, or if you could maybe speak a little bit to that space, I'd learn more.
Yes, absolutely. So, and like we've already talked about, you know, talking about intimacy after cancer is historically just not talked about. Unfortunately, patients aren't talking about it. Medical providers aren't talking about it. There is research that shows that they are not comfortable asking these questions, whether it because they don't know what to do with that information, they don't know how to help them, or they don't know who to refer them to. So when neither party is talking about it, these aren't getting addressed, but these are significant concerns. I think it's upwards of like 70% of breast cancer survivors have some type of sexual dysfunction. And it's not, as you said, it's not just about the pelvic floor. We think of, especially with hormone therapy, right? That's going to send people into menopause. And with that, they're going to have vaginal dryness. They can have pain with intercourse, but there's also, like you said, people who have, you know, these procedures, whether it be surgery or radiation, that significantly alters how they view their body and how they use their body with sexual play. And so we can take our skill sets as rehab therapists of teaching people about desensitization techniques, for example, or, you know, some of our pain neuroscience and graded exposure and, you know, kind of progressive relaxation with relearning their body, and maybe finding new erogenous zones that they can participate with. And it might just take kind of a body mapping. So you can kind of picture like a gingerbread person cutout and, you know, exploring with your partner. It's not just having the goal of penetrative intercourse and orgasm. It is playful. We need to find that play. And especially when we are at end of life, we're at metastatic spaces where everything is so heavy. So let's not try for having goal-based sexual play. Let's aim more for enjoyment, right? That we do that for exercise, right? We say, do something that's enjoyable to do. You like paddleboarding? Let's go paddleboarding. Like, let's figure out how to do that. It's the same thing with sexual activity. So helping them kind of relearn what's normal, what's not normal, exploring their body, exploring it with their partner. But also this can be a really great time to also work with another mental health therapist, especially a sex therapist is huge. If you're not familiar with the sex therapist, that they are mental health providers and educators who have additional specialized training and certification in sexual health. So AASECT, ASECT, is a really great resource to go to, and you can find people in your area.
That is such, I mean, I had a BMT patient recently, 2 years out, admitted for something unrelated and said, you know, when is it okay for me to have sex with my husband? 2 years out. And I almost cried. I almost cried. I mean, nobody had asked. Nobody had asked. And, you know, when we ask, I'm in the acute care setting, when I ask people, the therapists even, they don't have time to ask that question, even to do that simple, like the stress meter or something, right?
Yeah.
And it's just sad because it's a whole area that could provide joy at end of life, could provide, you know, playfulness, whatever word you want to use, intimacy, and we're not addressing it. So it really, I 100% am behind all of your work. Anyway, I could talk forever. You know that, Chris.
No, I could too, especially about sex and cancer. Like this is,
yes.
It's just, it's so important to talk about. This is part of people's identity. It's part of their relationship and a way for them to stay connected with their partner in a way that they can't be that with other people. So yeah, so screening for that, even after surgeries, even though, you know, I'm thinking kind of orthopedic setting, but I've had orthotherapists that come and they're like, hey, Alex, like my patient just had a total hip replacement. Like what positions can they do safely? I'm like, okay, well, let's think about like, what are their precautions, right?
Whatever you can do within your precautions, you can do.
Exactly. Or, you know, especially at end of life and within the palliative setting, looking at cancer-related fatigue and pain. How can we just use different bolsters and pillows and supports to decrease the amount of energy expenditure that they're using to hold themselves up, for example. So again, if you're a student, for example, like think about how you're going to position people comfortably on the plinth or in the hospital bed. And you can then utilize that and educate them how they can use that to still be intimate with their partner, for example.
Chris, do you want to close us out? Because I could talk all night.
So say, Chris, you gotta wrangle us in.
Take it away.
Jordan, take it away.
I was just going to say thank you so much. I truly think, speaking just for myself, you've opened my eyes completely, because I will admit I was one of those people that had some sort of stigma on this, and it doesn't have to be that way. And even if you don't specialize in it, it's still important to know and or refer those important people that can give people the right information in order to better their way of living, essentially. But I was just going to ask if you have any closing statements you would like to say.
I'm going to say no, because whenever I do, it goes off on another 5 to 10 minute tangent. But I do want to thank you, Jordan, for what you said. And I think that that's important in terms of just being open, right? Like I remember being in PT school and like we talk about pelvic health and you're like, oh, like we're talking about pelvic health, we're talking about the pelvic floor. Like, yeah, we're talking about the pelvic floor. Like
the muscle.
You know, there's a pelvic therapist that kind of coined the phrase of pelvic health as orthopedics in a cave. And it kind of is, you know, like it's, you have to look at it as part of the whole body. And so I'm grateful for you for kind of keeping your mind open. I hope that other people do too. There's a lot of easy ways to just bring this up for patients. They are likely wanting this information and you can open that door for them. So again, thank you so much for having me on for this amazing interview. Y'all did great.
Thank you. We were a little nervous.
Oh, you did fantastic.
You guys did amazing.